go ahead and start recording. Kirsten, you're up.
Thank you. Can you see my slides okay? All right. So today we are going to talk about breastfeeding, benefits, risks, and best practices. I'm going to turn my camera off just so there's no glitches. So this is often not something that we, necessarily talk about it from an infection prevention space. I know we do a lot of work in this space, but you don't see a lot of presentations on this. So I thought that we would talk about it today. So of course, funding for this presentation was provided by KDPH. Contents include discussion of unlabeled use of products. I have no financial interest or other relationships with manufacturers' products, and no commercial support was provided for this educational activity. So by the end of this presentation, you all should be able to identify key immune benefits that breastfeeding provides to infants, explain risks associated with breastfeeding with certain maternal infections, demonstrate the ability to implement infection prevention practices for nursing, pumping, and milk storage, assess barriers and disparities related to breastfeeding, as well as goals to increase breastfeeding rates, and design an education plan for new mothers related to breastfeeding and infection prevention. So throughout this presentation, you'll hear many different terms, each one a bit different, but the intent is really to show how the milk is getting from the mother to the infant. So breastfeeding is that overall act of providing milk to the baby from the mother's breasts. Now, exclusive breastfeeding means that the baby gets only breast milk, hopefully the goal for the first 6 months of life, until the introduction of solid foods. Exclusive pumping is a newer term that really just means the mother is providing milk from the breast through expressing or pumping that milk and then bottle feeding. Now, the baby does not latch on in this case, and this could be for many different reasons. But nursing is the act of actually putting the baby to the breast to be fed. And then, of course, mixed feeding would be a mixture of bottle feeding and breastfeeding, or mixture of breast milk and formula. And the reasons for the supplementation do vary regarding that. So to start really with this presentation, I want to be very mindful of the reasons that someone might not breastfeed, or they might not be able to breastfeed. This is an opportunity really to acknowledge the Fed is Best Foundation and their mission. Some women, there might be reasons that a woman might not choose to breastfeed. This could be prematurity, medications they're on, low supply or oversupply, mental health, galactosemia. They could have issues with engorgement, mastitis. There's also the concern of time and support. So the list really goes on, and the decision to breastfeed is a difficult one at times, but just know that a fed baby is the best baby. This presentation is just simply to educate on its benefits, risks, and best practices, but just remember fed is best. So the guidelines that you probably hear most of are from the CDC, World Health Organization, and American Academy of Pediatrics. So the CDC recommends exclusive breastfeeding from birth to 6 months, and then combined breastfeeding with the introduction of food until 1 year of age or older. The World Health Organization also says breastfed exclusively for the first 6 months, and then combine breastfeeding with introduction of food until age 2 or older. And then the American Academy of Pediatrics follows suit with the World Health Organization. So the human milk goes through stages of lactation. So you have your colostrum, which is from birth to about day 5. And then transitional milk is about from day 5 to 2 weeks postpartum. And then mature milk is after about 2 weeks postpartum, it starts to mature, and then it's fully mature by about 4 to 6 weeks postpartum. So we'll start talking specifically about colostrum. Production starts really at around 12 to 18 weeks of pregnancy, and then goes into the few days after delivery until it switches over to that transitional milk. So this colostrum is rich in secretory IgA, lactoferrin, and leukocytes. Colostrum is thick and sticky, and it can really vary in color from person to person, but it's usually like yellow, clear, or white. And it's produced in very, very small amounts for the first few days of life, but it does provide such a great deal of immune factors. Now, bellies of these babies can only hold so much in the first few days. That colostrum in these small amounts is usually enough and sufficient until they start to grow and able to hold more milk, in which the mother's supply follows, usually. More recently, colostrum has been used in premature babies in the NICU for infants receiving oral feedings who are not receiving oral feedings. There have been some concerns about them missing that oral pharyngeal benefit of the colostrum. So when they're not feeding by mouth, some NICUs are studying doing oral care with colostrum to improve the oral microbiome, which I think is pretty cool. So the human milk composition, once the milk has matured around 1 month, the composition then remains pretty similar, unlike that big shift from colostrum to transitional milk. So there are some small changes that occur over time with lactation, but largely that composition really remains stable. So the human milk composition at that point is really made up of macronutrients like protein, fat, and carbohydrates, as well as micronutrients like vitamin A, B1, B2, B6, D, and iodine. Now, one thing that breast milk lacks, or it has it, but not enough, is breast milk's not sufficient alone for vitamin D intake. So shortly after birth, breastfed babies will need 400 unit IU of vitamin D daily. And then from an immune perspective, obviously vitamin D has many uses, but from an immune perspective, vitamin D really helps the immune system to ward off bacteria and viruses. Now, moving beyond nutrition, we can talk about the components of human milk. So human milk contains macrophages, stem cells, immunoglobulins, cytokines, antimicrobial components like lactoferrin and lactohedrin, oligosaccharides, and mucins. So some of the roles, immunity protection comes from the mother while also helping to program the immune system. This is where the macrophages come into play. Now, some of the roles of the cytokines can play in human milk are regulating inflammation, wound repair, prevention of allergic diseases, thymic development, recruitment of neutrophils, intestinal development. And then there's some other functions that are being studied now, pro-inflammatory and repression of the Th1 type inflammation. And then it does stimulate the inflammatory immune system response activation. So the immunoglobulins provide great immunity. They provide pathogen defense to infants born with immature immune system, getting help from the mom's antibodies, which fortunately can be delivered through breast milk. So lactoferrin and lactohedrin also provide an antimicrobial effect. And then the human milk oligosaccharides, those are sugars that act as a prebiotic, which promote the growth of those good probiotic organisms in the gut. So those oligosaccharides are thought to influence the colonization of the gut microbiome from the very beginning of life. So you can see there's really a great deal of benefit from breast milk. And if you list all of those things out, you can see them here. Immune protection, immune system programming, regulation of inflammation, wound repair, prevention of allergic diseases, thymic development, recruitment of neutrophils, stimulation of the inflammatory immune response, antigen recognition, antimicrobial effects, protection from infection, and then, of course, the influence of the colonization of the gut microbiome. And then really neat thing about human milk is while it is packed with nutrients, it has been shown that infection can actually change the leukocyte content of human milk. So there was this study, the immune cell mediated protection of the mammary gland in the infant during breastfeeding. So it showed that maternal and infant infections can cause consistent and rapid increases in leukocytes. While the exact mechanism of that is not completely understood, the changes are there and they were evident in this study. So this was a review article in a symposium that occurred in April of 2014. And so they found passive and active immunity protections. The leukocytes may even protect the mammary gland. And so then after the infection is resolved, they then found that these leukocytes returned to baseline once they were well. So I think that's really cool to see the shift and change in the leukocytes. But some of the infections that they saw this response to was a maternal infection of hay fever, influenza, certain breast conditions and organ infections. And then for the infant, influenza, measles, and gastrointestinal infections. And so there have been many studies showing the protection against acute infections. And so for the sake of time, I won't go through all of these, but just know that you can find a great deal of studies out there. And if you're interested in any of these articles, I can certainly share them, share the links with you. But also there has been shown great protection against chronic and autoimmune conditions. I'm sorry, there's a fire truck outside. Breastfeeding and chronic and autoimmune conditions. So there are, again, several articles and studies done on that. Again, happy to share those links with you. If you are interested, just let me know. So now we've talked about all of the reasons why you should breastfeed, what the benefits are, but let's talk about the risks of breastfeeding with maternal illness. So maternal illness does fall on the list of why someone wouldn't want to breastfeed. Generally speaking, if moms have that mild illness, it might not be a contraindication for breastfeeding, but in some cases, there are risks associated with it that outweigh the benefits. So it could be that there's a risk of transmission of disease. It could be medications or drug use. Some of the other reasons just may require a temporary pause or permanent discontinuation of breastfeeding. But some of those reasons might be an infant with galactosemia, drug use, taking certain medications, or imaging requiring radiopharmaceuticals. Those are some of the non-infection related reasons. And now we'll talk about some of the infectious reasons. So these are some maternal infections of concern when it comes to breastfeeding. So if the mother has viral infections like HIV, human T-cell lymphotrophic virus type 1 or type 2, Ebola, active varicella infection, herpes simplex virus active with lesions, Mpox virus, and then bacterial, we can talk about active untreated tuberculosis and MRSA. And we'll go into each of those. So for HIV, it really used to be an absolute contraindication for an HIV mother, HIV positive mother to breastfeed. But now with antiretroviral therapy and the ability to suppress that viral load, there are new studies looking at the risk of transmission while on antiretroviral therapy. And there was a study called the PROMISE study that was released and published by the AAP. And it indicated that women on antiretroviral therapy while breastfeeding had a less than 1% transmission rate when they were their viral load was adequately suppressed. So the guidelines state that really the only way to have 100% prevention of transmission is to avoid breastfeeding altogether. But the CDC has kind of changed their guidelines and just said their breastfeeding contraindications are for moms who are not on antiretroviral therapy at all, or if they're on therapy but their viral load is not suppressed. So the biggest takeaway I would say for this is shared decision-making and education. For human T-cell lymphotrophic virus type 1 or virus type 2, mothers should not breastfeed if positive for either of these types. Active untreated tuberculosis. So this is really more of a concern for transmission when in close contact. So it would be a temporary pause of breastfeeding for treatment for 2 weeks and clearance from the doctor to be deemed no longer able to transmit the infection. Now the separation is needed, but the expressed milk can still be given in this case. And for active varicella infection, similar to TB, the concern here is that transmission due to the proximity, the illness could be spread when they're in the close contact during breastfeeding. So specific to this, again, they can have expressed milk is acceptable, but the mom and baby do need to be separated. And then for herpes simplex virus with active lesions, we want to avoid breastfeeding where there are active lesions present, but they may breastfeed on the unaffected breast if lesions elsewhere are covered entirely. Mpox virus, so isolation criteria must be defined and met before breastfeeding resumes, and there needs to be a complete resolution of lesions. So not unlike the other things that we've heard about Mpox, scabs need to no longer be there, fresh skin returned, making intact skin. MRSA, so methicillin-resistant Staphylococcus aureus. So most often you can continue to breastfeed. Staph bacteria do not transmit infection in human milk. It's really the transmission through direct contact with infected tissues. So you would want to avoid the infant's mouth coming into contact with infectious tissue or drainage. They could also express and discard the milk for 24 to 48 hours while they're initiating antibiotic therapy. But MRSA can be a cause of mastitis, which is what we will talk about next. So mastitis can be lactational or non-lactational, but we'll focus on lactational here. Typically, it occurs within the first 6 weeks, but it really can happen anytime during that breastfeeding journey. So lactational mastitis is engorged milk ducts with the entrance of bacteria from the skin. So you can see there's several different types of bacteria that can cause this. The signs and symptoms would be pain, redness, swelling, fever. It's very uncomfortable, and the risk factors for it is, unfortunately, if you've had mastitis, you're more likely to get it again. Nipple cracks and fissures, not draining the breasts adequately, stress, sleeplessness, which who doesn't have that with a newborn, and tight-fitting clothes, specifically bras. So treatment for this would be typically symptomatic, emptying the breast fully. They can use NSAIDs if they're able to take those for pain control. Heat to help with letdown. Cold packs after emptying can help decrease that swelling and pain. They need to continue to express the milk. If it continues to stay in there without expressing, they're going to have more problems. But if their symptoms with symptomatic treatment do not resolve within 12 to 24 hours, we should treat with antibiotics a 10 to 14-day course. To target SRS, we could use dicloxacin, cefalexin, or erythromycin if they have a penicillin allergy. They have risk factors for MRSA that you think MRSA might be causing this mastitis. You could do Bactrim or clindamycin. But Bactrim is not to be used in infants less than 1 month, and those jaundiced or premature. So consider that when you're prescribing this. If serious enough for hospitalization, empiric bank should be used until those cultures return. And then in addition to viral and bacterial infections, you could have a fungal infection. You could have a fungal overgrowth of yeast. This is typically Candida albicans. It can occur in babies' mouths, diaper area. It can even be vaginal yeast infections. In the mouth, you can have oral thrush or white oral spots. Moms can also experience this fungal infection on the nipples or in the breast. So some signs of that would be like sore, cracked, itchy, shiny, or blistered nipples. Also aching, sharp shooting pains in the breast we should consider fungal infection there as well. And baby and mom should be treated concurrently, so the risk of passing them back and forth is not as much of a concern. So sometimes during the breastfeeding journey, of course, pumping and expressing milk is necessary. So there are some infection prevention measures to ensure that risks are mitigated. And some of these include hand hygiene. If there's a use of shared pumps, then making sure we're using disinfectant wipes to clean them between. Pump and tubing inspection, safe, clean equipment and feeding items, following safe milk storage guidelines, and then taking care when thawing and feeding express milk to follow all of the guidelines. So for breast pump hygiene, you would want to make sure that you perform hand hygiene. When you put your pump parts together, make sure that you're inspecting them as you assemble, particularly because certain parts of breast pump part kits can hold water and condensation. So you want to make sure that you're inspecting everything as you assemble. And then once you're done, disinfect a shared pump, and after pumping, make sure we're following milk storage guidelines, clean the area, proceed with disassembling the pump parts for cleaning and sanitizing. And so this is a really great resource from the CDC on how to keep your breast pump and parts clean. I love this. I think we should give this to all breastfeeding moms or any mom who has the potential to be cleaning bottles of any sort, any parent or caregiver. I won't go through this whole thing with you, but I do want to call attention to this separate wash basin because I think a lot of people think that you can just wash your pump parts in the sink. But as we all know, the sink is loaded with bacteria and biofilm in the drain, which could inadvertently make our babies sick. So getting a separate wash basin and keeping those pump parts away from that is the biggest takeaway I want to show here. But again, great resource for your patients. As far as milk storage goes, educate patients on storing breast milk in storage food bags or food grade containers. Ensure that these containers are clean. Do not use items that are not intended for breast milk storage, so like bottle liners, which I think are less frequently used today. But make sure you're clearly labeling and dating expressed milk. You want to label bottles for daycare or anyone who might be caring for the baby, name, date of expression, and then you can insulate in a cooler for travel for up to 24 hours with ice packs. And this is also a great table from the CDC. You can do it tells you the type of milk and then where it is good for how long. So if it's on the counter, in the refrigerator, in the freezer, whether it's fresh, thawed, or leftover. This is super important information because we want to make sure we're not giving any milk that has gone bad. So you can get that from the CDC. Safe thawing and safe feeding of express milk. So never put breast milk in the microwave. It can get hot spots in it and can burn the baby's mouth. First in, first out rule. So if you put something in the refrigerator or in the freezer, you want to make sure you use the first one you put in will be the first one you take out. And then options for thawing per the CDC is to refrigerate them overnight or lukewarm water to thaw. Donor breast milk is a wonderful alternative if mom's breast milk is not available. Typically, it's done through milk banks for infants weighing less than 1,500 grams. If mom's supply cannot meet the needs of the infant. The biggest takeaway here is milk banks are safe, donors are screened, the milk bank handles the donations and distribution, the milk is pasteurized. Non-pasteurized milk sharing can be dangerous, so you want to educate your patients and families on the risks of bacterial and viral contamination here. So what if the baby gets the wrong breast milk? This is going to be dependent on your organization's policy and procedure, but you want to inform the mother who expressed the milk, discuss the milk mix up with the parent or guardian of the child who received the wrong milk, and then move forward to medical management, next steps, and diagnostic testing. Again, that's going to be part of your policy, so you'll just need to refer to that. But the biggest infections of concern would obviously be HIV, hepatitis B, and C. To prevent a mix-up, especially this is particularly for a child care facility from the CDC, make sure we have policies and procedures in place, train and retrain staff, make sure we're labeling, and then consider visual strategies as well. As we discussed in the beginning, some babies are not able to receive breast milk, and in the event that they can't have breast milk, then parents, guardians, and caretakers need to know how to safely prepare formula. Again, for the sake of time, I won't go through this in its entirety, but it is something that you can get from the CDC, which I also think is great for you to give to every new parent or caregiver, because at some point in time, it's likely they will need to mix up formula. But another thing I want to really point out here is the feeding guidelines, the storage and the amount of time that the milk is good for is different than that of breast milk. So it's always good to point that out to families and caregivers. In a healthcare setting, handling breast milk is a bit different. So we want to have dedicated breast milk refrigerators and freezers that are cleaned on a regular frequency. Policies and procedures should be in place. Have them clearly labeled individual bins, 2 patient identifiers, and barcode scanning is all helpful in ensuring that we're not mixing up milk. Dedicated space for aseptic technique when fortifying, and then for internal feedings, each new feeding requires new tubing, bag, syringe, and container. Again, in the healthcare setting, some IP measures, hand hygiene, sanitizing the prep workspace, following the MIFUs for cleaning and sanitizing equipment, using sterile water and sterile additives when needed, and then of course following those food storage guidelines. There are several different options for warming milk. The biggest thing I would take away from this is to follow your policies and procedures with this, and then follow the MIFUs when it comes to cleaning and disinfecting them. Maternal vaccination. Vaccines are so important for mom and baby. Most of them are acceptable to receive during breastfeeding. The only two really contraindicated during breastfeeding are smallpox and yellow fever. And antibodies from vaccines, specifically COVID, have been shown to pass through the breast milk. But the vaccines during pregnancy that provide passive immunity are RSV, Tdap, and COVID-19. And then lastly, we'll just cover this briefly. This just kind of shows the rates of breastfeeding at 6 months of age. And so you can see here in Kentucky, we're less than 54%. So this is a goal that we want to work on as far as improving breastfeeding rates. Disparities. We have seen disparities related to breastfeeding, particularly we can support and educate new mothers if we know these disparities. We've seen them in non-Hispanic Black infants, infants receiving special supplemental nutrition program like WIC, and young mothers, particularly in the ages of 20 to 29. Some barriers include latch difficulties, worry regarding intake and weight gain, medications while breastfeeding, work-related concerns, lack of support, and then if the hospital they deliver at doesn't support breastfeeding. Healthy People 2030 has goals to increase the number of infants exclusively breastfed through 6 months. So you can see the baseline here and the target for exclusive breastfeeding at 6 months and then breastfed at 1 year. So you can see that we have some work to do if we want to meet those goals. Lastly, just some education for new mothers, benefits and protection offered, talk about the lactation stages and nutrients, getting a good maternal history and physical to assess the risks of breastfeeding, knowing signs and symptoms of infection, talking about those infection prevention measures, educating and providing resources on milk storage and thawing, and then maternal vaccinations and resources. Also, it is important to note that lactation consultants are wonderful people. They're health professionals who assist with breastfeeding support. And it's not just breastfeeding. They can also assist with technique, latch, sizing for pumping, nutritional transfer. They can also help from an IP lens, assisting with mastitis, cracked nipples, engorgement, expressing milk, clogged ducts. And it is important to note that most health insurances do cover lactation consults. And then just some key takeaways. Breastfeeding can provide a wide array of immune benefits. Infection control and prevention measures can prevent infections during the breastfeeding journey. And barriers and disparities do exist, but providing education, resources, support, all of that can improve breastfeeding rates. And just always remember that fed is best. And these are my resources. And does anyone have any questions for me?
Any questions for Kirsten? There was a request for the slides, and so I can, if you want the slides, if you want to just send me an email, and we can send those slides if that's okay, Kirsten.
Yeah, absolutely. Yes. I talked really fast to get us through this. So for sure, if anyone needs that, just let me know.
Yep. All right. Well, thank you all very much. Again, apologies for the mix-up with the Zoom link. I'm not sure what that is, but we will get it figured out before our next grand rounds. So thank you all and have a safe week.